This is Dr. Babak Azizadeh. You are listening to the Smile Podcast, where I will be sharing with you my unique and holistic perspective on beauty, health, and wellness. Hello. Millions of people have surgery every year.
Or you could just get a boob job.
Using targeted Botox can be a miracle.
Smiling like that is a skill.
Your surgery has been successful. All right. So welcome everyone to the Smile Podcast. We're on Zoom during this coronavirus pandemic. And today we have Dr. Andrew Schroeder, who knows more about coronavirus, I think, outside of Dr. Fauci, because he has been obsessed and he is gone through all the evidence and all the information. He is an internist and a pulmonologist, so he knows a lot about not only the coronavirus, but what it's doing to people's bodies. And today what we're going to do is really get into a deep conversation about everything related to coronavirus so that you guys can have information that is evidence-based, not on conjecture, not on what's going on, in the lay media, but really bring science to you guys in a layman term so that you guys can have as much information as possible. Drew, thank you so much for joining us.
Thanks for having me back.
All right. I'm so excited. I think this is, an opportunity to give, up-to-date information to people. And there's so much, I'm obsessed with reading through everything, but it just seems like every day there's new information. There's a lot of stuff moving because of the government and the CDC and the FDA are constantly trying to approve new stuff. So what I want to do is just really get into very deep information that people can use for their knowledge. But first of all, how are you? How are you doing? What's happening with you?
Okay. I'm here in my home office in Los Angeles, and I've been actively treating COVID patients since the middle of March. Wow. And fortunately, I've been able to do telemedicine for most people. I've tested as many people as I can with the nasal swabs. I'm currently sending people for antibody testing that we can talk about later. But yeah, pulmonology is my specialty. The COVID-19 virus is a respiratory illness. It affects the cells that line the respiratory tract. We'll talk about other parts of the body later. But initially, the organ that it attacks is the lungs, and that's upper airway down deeper into the lungs. So viruses are a type of infection. The other type of infection people get are bacteria.
Yeah,
viruses
so
are
let's divide
different.
up that. What is, a lot of people are like, oh, I know what a cold is, but what's a virus? What's a bacteria? And maybe you could get into why this is wreaked havoc in the world, right, whereas other viruses may not have.
Right. So the difference between viruses and bacteria are both how they hurt people, the size of the infection or the particles, and then how we treat them. So viruses are very small. They have snippets, in this case, of RNA. And they basically get into a cell, they take over the cell, and they make the cell do things that are counterproductive to life. So, for example, when the coronavirus attaches to a respiratory cell, its only goal is to reproduce itself in that cell, and then the cell dies. Those are the cells that line the respiratory tract. So if you strip the lining of the respiratory tract, you're going to have problems. And that's fundamentally what's happening with coronavirus. Coronaviruses are the viruses that cause colds seasonally. Usually we don't worry about them too much because they have a pretty benign course. Unfortunately, there are people in the population who get the Corona-19 virus and really go down in flames, need hospitalization, end up in critical care, and sometimes die.
And so now we know that many more people than we thought are infected.
Right. So, you're talking about people who are infected with the virus without knowing it. So they become a vector for the virus because they're out in the community. And I'm sure, at this point, most people know the virus is spread through respiratory issues such as coughing and sneezing, and that can cause fomites, which are little drops of fluid with the virus in them that can land 6 feet away from you or so. And then it can be aerosolized, so it's even in a smaller particulate form and hang around in the air, for longer. That's not really something that happens so much in the everyday goings on in public. Aerosolization of the virus is more likely to happen in hospital settings when we're giving high flow oxygen or we're intubating people, and that's when doctors have to be extra careful. So the aerolized virus is not so much of a concern outside of the hospital.
So do you agree, or do you, to the precautions and the social distancing and how do you prevent this? If you're out there, I know what the government and the cities and all that stuff, but how are you, who knows a lot about this? What are you doing yourself and for your family?
So, for right now, we still don't know what the penetrance of the disease is in our community. We don't know who has it. It's kind of a silent disease that works its way through a community, and then you start to see people getting sick 5 to 14 days later. So since middle March, at least with my family, and I have 2 teenagers and my wife, we have stayed home. We have groceries delivered. We cook our own food. We do very limited errands, for example, going to the bank. And that's really it. I'm doing as much telemedicine as I possibly can. I've seen a couple of patients who I knew were safe. But really the isolation or self-isolation is the best way to deal with it. When it comes to masks, the N95 mask will protect you from inhaling the germs, from inhaling the virus. The communities are mandating in some cases that people must wear a simple face mask, or what we would call a procedure mask. And that's really, being a surgeon, you wear a mask in the operating room so you don't expose someone's open surgical field to your own kind of, fomites or breath or whatever.
Yeah.
So when you're wearing what I would basically call a cough catcher at this point, wearing a cough catching mask is helping people in the community to not get sick if you may have it and you would be spreading it without knowing it. So it's actually like, I think we should change the way we think about it. And it's a form of showing respect to the people around you when you're in public.
Yeah, no, I agree. I think that, it's really in Asian countries, that's what many people did as a respect. Like, look, I may have a cold. I don't know what's going on. I'm going to wear this mask. But here, I think in the Western nations, it was something like that was like, oh, that person is, why are they wearing a mask? Because they're
they're sick. They're on chemo.
The opposite, actually. So,
right.
So yeah, I think that's something that's here to stay for a period of time, I'm guessing, until we get to into a safer phase. So from a prevention standpoint, or preventing the spread, perhaps if you're wearing a mask, you could help control spreading, not so much maybe getting
you're not
it
protecting yourself.
Yeah, because you're not wearing an N95 mask.
Right.
Walking outside in the street, like let's say it's not a dense area. What do you think about that? Is that something that's fun. Safe, right?
Yeah, safe. Go have fun. Stay 6 feet away from people. Go exercise. Go enjoy your neighborhood. There's no issue there.
Okay. And so now why is it, and this is what I get asked all the time, or I think about it all the time, that in Milan and New York City, they went through a very difficult and very different experience than what we've gone through in California. Why do you think that happened? Is it because they have a different strain? Is it the environment? Is it the social isolating? What was it that you think made the difference between there and here?
I mean, these are my opinions. So I don't think we really know. I think they may have had a different strain. And I think their lifestyle, I've lived in Manhattan myself. The lifestyle is different. It's a culture where you're on subways, you're sharing taxi cabs. You really are shoulder to shoulder with a lot of people just in the comings and goings. Places like California, especially Los Angeles, is a car culture. And finally, our car culture may be paying off because we're in our
first time.
Yeah, for the first time ever. But we're in our little metal boxes, isolated. So I think it just in terms of space here in Los Angeles, people have more space and in the way they conduct their lives. So there's the possibility of a different strain, but also the way we live. And I think by the time Italy and New York were very early, obviously after China, but we were a little, we are more aggressive in treating people with COVID when they hit the door of the hospital. Like there really is an algorithm now, and there really are lines of defenses of drugs. There's no cure, but there are definitely drugs that mitigate the infection.
Like what?
So there's
and I know a lot of this is changing day to day.
Yeah.
So we're not holding you to like all the
right.
What's going on?
So there, I think of it as 3 waves of defense. So for mild to moderate cases, there is a growing body of evidence that if you do give patients hydroxychloroquine with azithromycin with mild symptoms, they get better faster. I think, people have different opinions, and there's no randomized controlled trials, obviously, because things are happening too quickly. But in the outpatient setting, it's the only pill available. The other drugs that you hear about in the press are all intravenous drugs. So if someone's in the community and they don't have cardiac issues, and it's being given to them by a doctor who understands, what side effects to look out for and who not to give it to, it's very safe and actually effective. And I've treated several people with it with good success. Once you hit the doors of the hospital and you start to decompensate, then there's the antiviral. So the antiviral remdesivir slows down the production of the virus, and that's showing good promise. The medical center that we're associated with, which is Cedars-Sinai Medical Center, is part of a national trial that's ongoing, and they're already publishing data in the New England Journal. If you get even sicker, the third line, when you're dealing in the intensive care with what we would call a cytokine storm, where all of a sudden your inflammatory factors are through the roof, and the virus at that point is secondary. The virus isn't driving this process, it's your own immune system storm. So then they use things that block a compound called IL-6 or interleukin-6, which is one of the big culprits in that cytokine storm. So then there's a variety of drugs there that are given in the ICU. So it's really outpatient pill, hospital IV, intensive care IV. So there really are kind of three different medicines that attack from different ways. But we're more aggressive with that in California because we knew about it at that point. There was some experience.
When would you say if someone has contracted coronavirus? Because sometimes I'm like, I don't want to go to the hospital. I want to see if I can manage this. When is it time to go into the hospital? That
when you can't? Yeah, that's a great question. It's a practical answer, and it's something that isn't in the media. You basically go to the hospital when you're sitting at rest and you can't catch your breath. That's when you go. If you tested positive at a drive-through and you're doing okay and you're treating your fever with Tylenol and you're drinking 2 liters of fluid a day and you're not short of breath at rest, then stay home. And I've treated a lot of people under those circumstances, and that's the majority of people.
And make sure you're talking to your doctor. Because you can't, this is not a self-treating.
Yeah, you need someone on the other end of the phone. Yeah, who's going to answer.
I'm calling you if I get it.
Thank you. Thanks. Yeah, I understand. I appreciate that. But it's really, I'm sitting, I'm resting, and I'm still not catching my breath. That's when you go to the hospital.
And then the other thing we talk about, and I think about all the time, is all the patients that do need to go to the hospital for other reasons and they're not. So one of the things that, people are having heart attacks, they're having chest pain, they're having, small strokes, and they're like, oh my God, I don't want to go to the hospital because I'm going to get a coronavirus. And because everyone's been like, stay away from hospitals and you could be causing more harm to yourself.
Sure.
Good. So that's the other thing that I would say I think the media hasn't paid enough attention to, because they've scared the daylights out of people for going to
Right.
the hospital. And there are a lot of times people go to the hospital for the wrong reasons. They have a
Of
sniffle,
course.
or they have this, or they have that, and so forth. But it's also important for our viewers and listeners to really make sure if there is something going on. You're having abdominal pain that you can't control, and you may have appendicitis, you may have a heart attack, or you may have other things. Make sure you go. But there are times also, like if you have a laceration, call your plastic surgeon, local plastic surgeon, or someone, so that you don't have
Right.
to go to the hospital. So
Right.
it's important to distinguish that. So Drew, testing. I know there is a million things out there for testing, because now, as we had predicted, there are more testing options available. A month ago, it was like, oh my God, where am I going? Now every doctor I know is like, oh, I got this test. Oh, I got that test. Can you go over the different, like the big picture of what the different testings are,
Sure.
how the consumer should be confident, and there's no 100%, that the test that they're receiving is a validated test, and
Right.
give us some information about that.
So, there's two ways of testing. There's a test to see if you have the illness now, and then there's a test to see if you had the illness. So the first test is a swab test that looks for the RNA of the coronavirus, and that's using a PCR technology. And that is either given up the nose, or in some cases in a mouth swab. And I have a feeling that they do the mouth swab in some drive-thrus because they don't want to cause nosebleeds, right? So you don't want to have someone in their car cause a massive nosebleed and say, please keep moving.
Yeah.
So I think that's why I'm hearing about mouth swabs. I think the yield on the nasal swab is probably better,
Higher.
Based on where you find the actual virus in the body. But those are ways to tell whether or not someone has an active infection and they're shedding virus. In my opinion, and I think in the opinion of a lot of doctors, we should really expand that testing. People, if they have minimal symptoms, should be able to get the test. Or if they're in a sensitive area where they're going to be exposed to people and they don't have symptoms, they should be able to get a test. For example, like a grocery store clerk who, sees a new person every 2 minutes, for their whole shift.
Yeah.
So those are tests to see if you have the virus. The antibody tests are tests that measure the proteins that our bodies make as a result of having an infection. So there are 3 types of antibodies which will go up when you're first infected. The first one to go up and spike is called IgA. The second one is IgM, and the third one is IgG, which is your long-range immunity. The tests that are available to look for antibodies are the IgG and the IgM. They're skipping the IgA because it just goes up and down very quickly. So those tests are hard to create, because part of what you need to do to power these tests is know the penetrance or the amount of the illness in the community. So and that's called positive predictive value. So you need to know how much you can trust a positive test. So if you have a test that has a positive predictive value of 95%, which is high, but the test is only the illness affects only 1% of the population, the positive predictive value is very low, right? So you can't really trust that test. If all of a sudden the prevalence of the disease goes up to 30% in the community, then you can trust a positive. So, this is a long-winded way of saying we didn't have one of the factors that goes into figuring out how sensitive do we make a test. So, as we get more information on antibody studies to really get quantitative antibody studies, not a yes, no, not like a pregnancy test plus minus, we'll be able to refine the test better. And I think the major labs are doing that, and they're doing a good job. At first, there were the finger stick, pinprick finger stick tests. And, I ordered a couple for myself and for my own office staff, but I personally would not do those on patients, because if they had a positive antibody, I'm not releasing them into the world telling them that they have a positive antibody, because I don't know whether or not to trust the test.
Yeah.
So, taking this in for a landing, there will be good tests available. They're going to be blood draw tests. They're going to be through major labs. And knowing your antibody status will help with returning to work. It'll help with travel documents, and it'll help with student housing.
When do you think that's, I mean,
that's happening now.
Yeah. So you think in the next 2 to 3 weeks, that's going to be
now. Yeah.
Yeah.
The major lab that I work with, it has their test going now, and that started on Monday.
Okay, perfect. Because the way I'm thinking for my own practice is, okay, who am I going to test? Is my staff going to be tested? Are the patients just coming for routine check-ins going to get tested? Definitely patients who I'm taking to surgery will need to be tested because, they're getting intubated and so forth. So what's going to be the protocol of how we get back to normal in healthcare? What do you think that will be? This is just for my own curiosity.
No, and I know. And what test result would you cancel a surgery for?
Absolutely.
I don't think there is one right now. If they're positive, that means that they had it. It doesn't mean they have it. And if they're negative, that means they're okay. So you're not canceling the surgery. And actually, we were talking about this offline before.
Yeah.
I don't have a way to check IgA at this point. So IgA is the only hot one where it's within a week where someone would be shedding the virus. So
maybe asymptomatic.
Yeah. So I'm thinking there needs to be a more rapid PCR that we put in the nose that could detect viral shedding rapidly.
Yeah. How about the Abbott system, the 1 hour
system
that they're doing?
I think that's as good as it gets right now. Those machines are hard to get. I signed up the day they came out. I haven't heard anything, and that was weeks ago.
Yeah. Yeah. So it's a moving target.
Yeah, it's developing so quickly. It's. I'm afraid by the time I get an Abbott machine, it'll be obsolete.
Probably.
Yeah.
So what do you? Okay. So based on the current evidence that we have, we were talking before we started the podcast about where you think this is going, and you shared with me a website that I'm going to put up right now. I'm going to share the screen with. Where do you see this kind of evolving, where people can feel a little bit safer to be able to go out and interact and socialize, and maybe go to a socially distant dinner with friends or family and restaurants?
I see you putting it up.
Yeah.
Are you putting it up? Okay.
Oh, yeah.
So this is kind of my morning routine, is looking at this website, which is put out by the University of Washington. And they have, in my opinion, the best modeling. And there are 3 curves and you can look it up by location. So this curve corresponds to the entire United States. And the line that the cursor is on is today's date. And this is the curve that has reported and projected deaths. So you see Dr. Azizadeh is marching it out to, May 30th. The projected deaths is what, 0?
This in the United States.
This is the U.S.
Yeah, this is the U.S.
So take us to 0. What's the date?
It's going to be early June.
Okay, so that's for the entire country. So one thing that happens in the media is they compare us to Sweden. So we're 32 Swedens, right? So we're a heterogeneous society that's both geographically, economically, and culturally different in a lot of ways throughout the U.S. So it's unfair to compare us like that.
Of course.
So, that's composite U.S. So if you go to California, which you just did, you'll see a different curve. And then you look at the curve there and look at 0 deaths.
May 14th.
May 14th. So that's an entirely different date. So these are the kind of things I'm looking at. So why is California different from the rest of the United States? California is different because we accomplish social distancing and we live in a car culture. If you look at New York's curve, or pick a state, doing in New York, you'll see New York really spiked before we did. And the line, the jagged line is actual data, and then the shaded area is projections. And I can't see it because it's too
Yeah,
small, but
they go to like 1 or 2 by late May 18th.
so it's interesting. So you can see how that state got hit
0
harder
by
than
May
we did.
23rd or May, yeah, May
Yes.
22nd, they go to 0.
So what's the difference? The difference is they got hit much harder than California did. So if you look at raw numbers, if you go to the peak, where why don't you march it back to the middle of that curve?
Yeah.
You know, how
April
many
9th.
deaths per day are there?
Yeah.
It's in the thousands, right?
Yeah.
So go back to California and let's see what our worst day was. And I think that was maybe April 16th.
Yeah, April 18th was our
18th.
peak.
And what was our worst day?
103.
Right. So a factor of 10 less, or
Yeah.
you know, even more than a factor of 10 less. So, you know, we talked about the various reasons why it would be different. But the worrisome part that we're all dealing with is how do we reopen society? So that's both a public health question and an economic question on people's minds.
Yeah. And what's herd immunity? Because I think when you were trying to discuss Sweden versus us, their mentality was, okay, really, let's get to herd immunity quickly so that we can get this virus out of our system. And can you give, the audience a little information about herd immunity?
So herd immunity means that there's enough people with antibodies, whether it's from having been ill, for example, with coronavirus, or from having a vaccine, which doesn't exist yet, but it will, to protect those people who are still vulnerable to the disease. So I'm doing this off the top of my head, but really the idea is that one person with coronavirus would infect 3 other people, roughly. Right. So someone can correct me on how much of the herd needs to be immune, but I think it's in the 60% range. Yeah. It doesn't have to be 92%, So, and what factors into that is how communicable the disease is, or the R naught, which I mentioned before. 1 person infects 3. So the magic result would be if we check enough immunity through antibody testing that we can see how solid the herd is. We can all relax a little bit more.
Yeah.
My gut feeling is I don't think we have herd immunity in California.
No. And I think it's going to take much longer.
Yeah.
That because we kind of were able to really dampen down that curve. Right. Because, for instance, I was on a conference call with Cedars about the hospital and so forth. They were expecting at the surge 800 coronavirus patients. The maximum I think they got was 120. Now they're at 80.
Right.
So this is like sevenfold lower than what they had expected to get. So that means there aren't that many people, infected. And I think the USC study showed only 4%. Right. Roughly. Whereas in New York, I think right now some studies show 21%. Right. So yeah, and I think Sweden, if I'm correct, they said, okay, let's keep like people at risk who are over 65, have health issues, socially isolated and distanced. Let everyone else go out there and essentially get it.
And I think the reasoning there was this is still a disease that affects people on cruise ships and nursing homes the worst.
Yeah. For sure.
So let the people who are in the community go about their business and be sensible and responsible.
Yeah.
And we'll see if that was the right thing for Sweden to do when we can analyze this months down the line.
It's going to be very difficult to know. So who are at risk? Because there's been a lot of, we see, so many people that are, well known dying from this, who've gotten it. You hear about younger patients, you hear about obviously nursing homes. Who are truly at risk, Drew, based on your experience and what you know about it?
I mean, currently the people most at risk are people with heart disease, diabetes, and obesity. They don't break out smokers, but I would guess that, being an active tobacco smoker would put you at a higher risk as well. but those statistics are not available yet. I think there is also going to be, when we dig deeper, why is it that this cold virus, some people don't feel it, but some people go down the tubes? Why do they die? Why does a 40-year-old nurse die? And I think what we're going to find out, and this is something that should be studied, is that the people who really decompensate have a different IL-6 response to the disease than other people do. So there probably is some inborn difference in those people that never really, didn't express itself until now.
Yeah.
So that still needs to be studied, but I have a feeling that IL-6 metabolism or other cytokine metabolisms in the people who died was not normal compared to the rest of the population.
When are you planning on going back and seeing patients? You're in Los Angeles and you're in Beverly Hills.
Yeah.
When are you planning on doing that? And how have you thought about how you're going to change the flow of patients in your practice?
Absolutely.
And what have you thought about?
Absolutely. And look, architecture is going to change, right? The way things are laid out is going to change. And my office architecture will not change, but there will be less people. There will be less people in the waiting room. There will be less chairs in the waiting room.
Yeah.
Patients will be screened by phone ahead of time, the day of the appointment. When's the last time you had a fever? Are you coughing? That's a little difficult for me because I'm a lung doctor, so there's a lot of coughing going on. When the person comes, they need to have a mask on. They're going to have their temperature taken immediately. Each doctor in the office is going to have one chair in the waiting room, and they're going to be more than 6 feet apart. And if someone's actively coughing, we're going to tell them to come back, or if they can get into a room immediately, then that's okay. Then, every room will be wiped down after each patient, and, we'll go from there. And really it's a forward flow through the office, meaning you don't go backwards. So you come in one door and you leave in the front door, out the back door.
Yeah.
And, no chit chat, no hanging around, no catered food in the office anymore, no unnecessary personnel.
Visitors.
It's just going to be, just clean patient care in and out with screening at the front.
What do you think I should do for my patients preoperatively, for my surgical patients that are maybe flying in, maybe local? What do you suggest?
This is a tough question. And if we have a rapid PCR for shedding the virus, I think when they get to Beverly Hills, they can come get a nasal swab and then leave. And then 48 hours later or a day later, find out what the results are. And if they're okay, proceed with the usual preoperative evaluation. But I think actually actively testing for the virus is where it's at. I don't, I've changed my opinion because we can't get IgA. Like, I don't think antibody testing is going to help in a pre-surgical environment. That said, if you're drawing blood, I think it's nice for everyone to know what their antibody status is. Yeah.
I think if we double up with both the PCR and getting the antibody, you can have, I think, a higher certainty and confidence. And again, I'm not, an expert like you, but to me, based on what if you could have those all align, then you could say, okay, you know what? The chances that, let's say somebody in the population has an active disease, let's say in about a few weeks, right? It's going to be less than 1%. Then the chances that with these negative tests, they have disease that's active, it's going to go into 1 in 1,000 or 1 in 10,000.
Right.
And you're like, okay, you know what? This is like a very, very, I'm confident, not 100%, but I'm confident that this person is not going to be harmed, because we don't want to harm people. That's the most important thing, because surgery in an asymptomatic patient can potentially harm them. So we want to make sure that we're doing everything we can in a safe environment, but we also don't want to delay care for a lot of people.
Right.
Because then we're going to get into different problems 6 months from now, a year from now, and how we're impacting their lives. So
yeah, no, and I think of you, and then how are you going to gown up?
Yeah.
Right? Like, how much stuff do you have to wear? How much do you have to sweat underneath all of that personal protective equipment and do your surgery? It's insane.
Yeah, we'll do whatever it takes. We want to be safe. We want to be safe for the patients, but I think as the testing, and you've really nailed it, as the testing gets more and more accurate, easier to do, more rapid, I think we're going to be able to identify. Today, I was talking to a company, really, really interesting. I'll share the information with you. It's interesting that they're going to do a herd testing for companies, so that they don't need to
Great.
test, so they know, okay, this pocket of people are safe, and if something,
That's
so there,
epidemiology.
yeah, so I think there's going to be, over the next few months, as we learn more, we're going to have more confidence in what's going on, in going into our restaurants and going into our, shopping malls, whatever it is, and kind of get back to hopefully a more normalcy.
And this is less medical, but it's interesting. I was talking to someone who works for a major clothing company, and they're wrestling with decisions of, are we going to let people try on clothes? What do we do with the clothes once someone tried them on and they didn't
or
buy
they
them?
return it? Yeah.
Do we throw them away? Like, do we clean them? How do we clean them? Do we buy a machine that messes up the clothing by cleaning? It's all these questions. Like, I don't, I'm not going to go try on clothes somewhere. Right?
Honestly, I didn't even think about that. Think about it.
And then how do you keep the employees safe? And then in the restaurant, are they going to take out half the tables? Like, how is that going to look?
Well, I have a friend in Hong Kong, and that's what they've done. So Hong Kong is a couple months ahead of us. And what they've done at bars aren't open yet, but restaurants are open, but you can only seat 4 people to a table. They're socially distanced, right? 6 feet apart. The waiters and waitresses wear masks.
Right. Paper menus.
And it's, and then you have to think about the restaurants, right? If they're serving half the people that they're normally serving, and how are they going to make it, right? And then are they going to charge more? And as they charge more, less people are going to go, because they have to be able to make, essentially, be able to be profitable.
This is going to have ramifications for a long time, and it comes down to changing people flow and changing architecture of how the environments we're in.
Yeah, no, it's really unfortunate. I know that a lot of people have been hurt physically with this, but there's going to be, long-term repercussions for society. So it'll be really interesting to see. I want to thank you, Drew. This was amazing. I think whoever's listened to this, I think they have a lay of the land of what this coronavirus has done, will do, and also just have more knowledge base so that they could be educated with real deal information from a major expert. And I can't, let's do this again in a few weeks, because I think this is a moving target, and as much information as we can give to people, I think they'll be able to have more information and stay safer. Okay, so Dr. Andrew Schroeder, he is, as I told you, an internal medicine and a pulmonary specialist in Beverly Hills, and has a amazing practice, and great doctor, and my own personal doctor. And I'm just really, really glad for you to spend this time. I know your time is valuable, and I appreciate it.
Thanks. Thank you, Bob. It's my pleasure.
All right.
Thanks.
We'll see you guys soon, and please give us comments and suggestions. And we look forward to the next podcast.